Okay, so we're going to make a start as it's 9:30 and we've got a really busy agenda. So my name's Emma Adams. I'm a member of the Q community and I will start sharing my screen so that you can see what we're doing, and also to let you know that we're recording everything. So if you want to look back another time or you want to share with your colleagues, then please feel free to do so. So good morning and welcome to our webinar on quality management systems. As I've introduced myself, I'm Emma Adams and I'm co-hosting with my colleague Joy Furnival, who hopefully can wave at the camera at this point. Morning, Joy. So welcome to the first of 4 webinars that we're hosting over the next 6 months on quality management systems on behalf of the Q community. And if you don't know who the Q community are, well, we're a connected community of thousands of people interested in healthcare improvement across UK and Ireland. But we love talking with other people about quality improvement, so it's great to see people from elsewhere. So in the spirit of sharing and collaboration, Joy and I have got our heads together and we felt it was important to take a deeper dive into quality management through these series of webinars. So for today, I'm going to quickly introduce who we are and then also introduce our speakers. I might need to check that one of them is on the line. Shah, if you could just check, that would be great. So, as I said, I'm Emma Adams. I'm a Q community member and I convene a number of special interest groups. I have a deep interest in quality management systems and support organisations to implement them. Joy, do you want to quickly say hello as well?
Yeah, hello everybody. I'm Joy Furnival. Nice to see you all here. I currently work as the Chief of Regulatory Compliance and Improvement at the North West Ambulance Service, but I have been quite active in Q over the years, so it's really nice to see you all here and it's great to collaborate with all of you. Thank you.
Okay, so I won't ask our guests to introduce themselves. I'll ask them to do that when they do their talk, but I just want them to wave when I say hello. So our first guest is Michael Canavan from Healthcare Improvement Scotland. So Michael's waving at the moment. So Michael's the portfolio lead on QMS in Scotland. Our second guest is Dr Amar Shah. Good morning, Amar, who's a consultant forensic scientist, psychiatrist, at East London Foundation Trust, but is also their Chief Quality Officer and the lead for the Royal College of Psychiatrists on mental health. So good morning to you, Amar. And last but not least is Dr Nicola Burgess, who's Reader in Operations Management at Warwick Business School, who has a deep interest in service improvement, lean, and all things healthcare improvement. So thank you very much to the 3 of you for joining us. And thank you to everyone who's come along. So that's us. That's what we look like, and you can spot us as we're talking. So just to let you know, in terms of the session, we'd appreciate it if you stayed on mute while we're presenting, as sometimes there's background noise. The chat's open throughout, so please use it. Post any questions, we'll try and monitor that as we go along. We've asked our presenters to talk and then you can ask them questions later at a panel session, but raise your hand if you'd like to speak and we'll spot you, but also post it in the chat as well and we'll have a look at that. If your tech fails, don't worry because we're recording, so we'll post everything on the Q website, which you'll be able to find if you sort of Google that. And please feel free to use Twitter because we like Twitter a lot in the Q community. So we're using a Twitter hashtag and we also like to use the @the_Q community handle as well. And don't worry if you are disturbed because we've spent many times on webinars these days, so we know if the cat or the dog or the window cleaner comes, then that's what happens. We'll also record the chat so we can pick up some of the themes to share for later. Okay, so just a brief outline of how we're doing this. So we'll start, Joy and I, and we'll give you a little bit of an outline of the series that we're running over the next 6 months. Then I'm going to hand over to Michael, and he's going to talk us through some of the work that Healthcare Improvement Scotland has been doing around quality management systems. Then after that, I'll be handing over to Amar, who will be talking about quality at an organisational level in East London Foundation Trust. And then we'll give you a little chance to meet each other. So part of Q Community events is always to say hello to someone else who's working in a field like you. So we'll give you a chance to meet each other and just pose a couple of comments, thoughts, that kind of thing together. And then I'll hand on to Nicola, who will be talking us through the evaluation of the sites in NHS England that have been sponsored by Virginia Mason Institute and what they have learned through the implementation of that model. Then we'll move to a bit of an Ask the Panel, and then we'll close. So we've got lots to get through, which is why we'll go fairly quickly. So first things first, let's see where you're from. So you can use the annotate function on Zoom. So if you look at view options at the top, so you'll see this little square. If you look at view options, you should be able to find an annotate, and that should allow you to stick a little dot or spot or heart, hello Seema, on our little map. Okay. So put where you are. Oh, lovely to see you. If anybody's, there is a world map as well if you want to try and get yourself on that. Fantastic. Oh, that's lovely to see. It's really great to see so many people who are coming from lots of different places. Fantastic. Okay. That's lovely. Right. So I am going to move us on in the interest of time. So can you please now take your annotate off? Otherwise we won't be able to see the slides.
I think you can do it as well, Emma.
Can I do it? Can I? How do I do that then, Shah?
This is from memory. If you go to view options, can you see
clear all drawings? Yes, lovely. Thank you. Okay, so we started our inquiry into quality management systems last year with an initial webinar for the Q community. So if you want to have a look at it, you'll find it on the Q community's website. And what we did was a very high level look at QMS, and we realized that people wanted to do a much deeper dive into this. So following our discussions, I think, can somebody mute?
And again, that would be
try. So following our discussions, we agreed with the Q team to come up with a series of 4 webinars that would give us the opportunity to dive deeper, learn from others, and share what we're doing. So just take you through, hang on a second. Okay. So the 4 webinars that we are running is today's webinar. So we're looking today at the principles and mechanisms that organisations might apply to deliver whole-scale organisational quality management. We're also going to look at some of the different levels of organisational maturity and give you a chance to think about where might you start. And then the second webinar, we're calling Putting the Man on the Moon. So using the apocryphal story of the cleaner at NASA. So how do we align everyone to understand what's their role in the organisation, and how do they know what it is they should do, and how should they use their time and their efforts? And we'll be learning from places that have really started to move on this and to align their strategy throughout their organisation. And then the third webinar, we, following feedback, are really going to focus on that daily quality control. So how do you make QMS a reality through the routines and the habits and the processes that you do on a daily basis? And again, we'll learn from places that have started to experiment with things like Toyota Kata and other methods for daily control and visual management, lean, that kind of thing. That's what we'll do on webinar 3. And then on webinar 4, we'll be really thinking about what does it take to lead in these circumstances? What are the conditions for success? What's the leadership you need to show? What's some of the soft things around relationships, conversations, attitudes and culture that will help us to establish a whole organisational focus on quality management? So that's where we are. So what we're now going to do is I'm going to hand us over to Michael. And I just want to check that I've got Michael's screen right. Okay, so Michael, I'm going to hand over slide control to you and let you take it from there. So Michael, would you like to introduce yourself to the group?
Thank you very much, Emma. Good morning, everyone. My name is Michael Canavan. As Emma said, I'm the portfolio lead for the QMS portfolio within the Improvement Hub at Healthcare Improvement Scotland. And I'm delighted to have the opportunity to share our Healthcare Improvement Scotland approach to quality management. But equally, I'm really looking forward to the opportunity to learn with and from everyone who joins the webinar series over the next 6 months. I think there'll be a lot to share, a lot to learn, and a lot of experiences to sort of pick up from others. So I'm really looking forward to all of the sessions coming up. So as I said, I'm Michael Canavan. I'm the portfolio lead for quality management systems within Healthcare Improvement Scotland. I'll tell you a wee bit more about what we do and what Healthcare Improvement Scotland does just shortly. But in actual fact, healthcare improvement. So this is what I hope to cover just in the next 50 minutes or so. So an overview of what Healthcare Improvement Scotland does, our approach to quality management, probably a wee bit more about our evolving thinking about quality management as we're working with other organisations. We're learning all of the time and our thinking is changing constantly. And I'll finish off with a very brief introduction to some work that we've done around learning systems. And as you'll see shortly, we've placed learning systems right at the centre of our QMS framework. So Healthcare Improvement Scotland is one of a number of special boards. So NHS Scotland is made up of 14 patient-facing territorial health boards providing services to patients. And there are also 8 special boards, or sometimes called national boards. And Healthcare Improvement Scotland is one of those national boards. And you can see here, this is our purpose, which is about enabling people in Scotland to experience the best quality health and social care. And we do that through a variety of support functions. So the Improvement Hub, for example, the directorate that I work for within Healthcare Improvement Scotland is about supporting those NHS territorial boards to improve and redesign their services. We also have a Quality Assurance Directorate, which is about assurance and scrutiny. We have a Community Engagement Directorate, which is about helping to ensure that we have good engagement with people who use the services. So there's a whole variety of functions that Healthcare Improvement Scotland provides, but that there is our purpose. And QMS helps us to make sense of how all of our different offers into the system work together to deliver our purpose. And you can see here just a short quote from our recovery and remobilisation plan, where as we continue to review and refocus our work, we think about how we can use quality management to think about the combination of functions that will be most effective in the key delivery areas. So when we talk about quality management systems, this is what we mean. So a coordinated and consistent approach to managing the quality of what we do across the whole health and care system. And that's with the ultimate aim of delivering better population health and well-being, better care experience, better value, and better staff experience. And we developed our quality management system framework working with a whole number of partners, including IHI and Scottish Government, and a whole series of focus groups. And Angela, my colleague, who's also on the call today, is going to share in chat a link to our resources for QMS, including our final report from that 90-day approach that we used. So that's what we mean when we talk about quality management. And as well as the report, we came up with a high-level visual framework identifying what we think are the core components of a quality management system. And you can see clearly there in one of Emma's first slides, when she talked about quality management, she had Duran's trilogy, and quality assurance is really key. And that's what commonly we refer to when we talk about quality management, that Duran trilogy of quality planning, quality control, and quality improvement. And as I mentioned earlier, we have learning system sitting right in the center of that. But we've also identified a number of other components, including really thinking carefully about a clear vision and purpose that people can create a visceral connection to and really understand their role in delivering that vision and purpose. I think what we've seen from successful organisations delivering quality, leadership and culture is extremely important. And then all of this is founded on a platform of co-design, co-production and relationships. And I'm sure most of the people on the call today will have heard the phrase, in quality, 80% of that is about relationships and 20% is about technical tools. So we recognise from all of the work that we did as part of our 90-day cycle and the feedback that we got, the crucial importance of really engaging with and involving the people who use the services, so that we're doing with and not doing to or doing for. And then around the outside of the framework, there's the aspect of quality assurance. And I'm going to just build a wee bit more on each of these. I think just to sort of highlight some, as I say, some of our developing thinking. So you probably notice straight away that we don't talk about quality planning, but in actual fact, our third iteration of our framework has changed from quality planning to planning for quality. And we're probably also thinking that we might think about changing the wording around quality control and quality improvement. And the reason for that is we've found that one of the key barriers around quality management is some of the language. And some of the language that's not accessible to people who are not as familiar with quality improvement as most of us will be. So what we found just around quality planning is, even in our own organisation, there was some confusion and some conflation with the processes that we use on an annual basis to do our operational planning. People were picking up quality planning as the level of quality to the planning that we do on an annual basis. But when we talk about quality planning or planning for quality, what we mean there is taking the time to really understand what is it that the population or the service users need. What are the assets out there in the wider service community that we can use to understand that and deliver those services? And from that information, start to actually prioritise our plans for high quality services and improvement. And of course, we're going to use the data that we get from our quality control. So again, one of the other things that people have fed back to us is quality control creates a bit of a barrier and a bit of a confusion, and can almost sometimes present and reinforce that notion that systems are there to be controlled and manipulated and managed. But again, I'm sure that most of us on the call understand that quality control is about using the data that we have to monitor the level of quality of the service that we're providing, and to help us understand when those standards are slipping or improving. And all of that can help us then think about what we need to do to improve that. So we're constantly thinking about how we can communicate this in a more meaningful way. And in actual fact, when I think about my very early career in nursing, before I was ever introduced to the principles of quality improvement and improvement science, you know, I worked with 2 charge nurses in a coronary care unit who way back in the 1980s were taking the time to understand how long it was taking patients to get from A&E into coronary care for their thrombolysis. And they quickly realised that it was taking too long. So they were actually looking at the data at that time to understand, are we treating our patients optimally? And we understood that we weren't. So we identified plans to change what we needed to do, and made improvements to improve the door to needle time for patients coming in with myocardial infarction. So way back then, our charge nurses were trying to apply a quality management approach. And I think that highlights the fact that organisations and services all over the country are using quality management principles, but sometimes don't even realise that's what they're doing. So sometimes the language can create problems and barriers. So that's our framework. And like every framework, we often say we don't think this is the way that everyone should do quality management. We don't think this is the ideal model. In fact, we use a quote from a gentleman called George Box, who says, not all models are perfect, but some are useful. And we find this useful to help us think about how do we get the balance right between all of these things to ensure that we're delivering the highest quality services possible. So moving on, I think just to highlight again the importance of co-design, co-production and relationships. So I think we all recognise that the Durand trilogy came from the manufacturing industry, where they're mainly dealing with processes. And I think we all recognise working in healthcare is quite different from working in a manufacturing process. And it isn't an adaptive or a complex adaptive system. So I think it's really important that we do whatever we can to ensure that we are engaging effectively with those people who use our services to co-design and co-produce high quality services that meet the needs of the people who use them. And I also just wanted to highlight another area of learning for us. So our first iteration of our quality management framework had quality control and quality assurance in the same bubble in the centre. And working with internal teams and external teams, we very quickly realised that that wasn't helpful. And in fact, we were actually leading people again to confuse and conflate two completely different aspects of quality management. So quality assurance is about those independent checks for quality that can be done by teams themselves, and we might also invite an external agency in to do those independent checks. So we decided that we should absolutely separate out quality control and quality assurance in recognition of the fact that they are completely different. And we've now put that around the whole of the framework. The idea being that its role is there to assure the effective functioning of a team, an organisation, or a system, and their whole approach to managing quality. So we're kind of learning all of the time. So moving on just to the learning system, and I think in our experience over the last few years, I think we have seen throughout the pandemic the real need for timely learning systems that enable us to learn quickly, to gather insights and make sense of new knowledge, new evidence, to actually lead to new action and new developments or new improvements to improve outcomes for patients. And I think we've seen so much of that throughout the pandemic. And as part of the work that we're doing to support the NHS health and care system in Scotland, we know that there are a whole variety of learning systems popping up across the whole of our healthcare system. And we decided that, or we realised, sorry, that describing learning systems was difficult. It was probably one of the most difficult aspects of our quality management framework to describe and explain. And recently we've taken some time to actually think, how can we help healthcare systems, healthcare organisations to think about how they might go about establishing their learning systems. So we've taken some time to describe what we mean by learning systems. We've taken some time to think about how teams, services might establish their learning systems and giving some advice about what the core components might be. And our next slide just gives a high level visual of how you might go about establishing a learning system. And there might be an opportunity to come back to this later on in the webinar series, but I know that Angela is also going to attach in the chat a link to some web pages that we've developed. And those web pages just delve a bit more deeply into what do we mean by the supporting structure or the supporting infrastructure? What's required to really help you think about getting that learning system up and running? But also taking some time to carefully think, well, what's the purpose? What is it we're trying to learn about? Who needs to be involved and how? And again, we'll probably all recognise and be very familiar of all of the inequalities that have surfaced as a result of the last 2 years and the COVID pandemic. So we're encouraging people to think right from the outset, what do you know about inequalities and how can we apply our learning systems to try and tackle some of these inequalities right from the very beginning? And then taking some time, as I mentioned earlier, to use the intelligence, the experience that you have, the wisdom that you have around you to gather insights, to gather the evidence, to gather the knowledge, and then to make sense of that before turning that knowledge into action. And we recognise the importance of good, effective networking to enable that to work well. The other thing that we've highlighted is the importance of evaluating right from the outset. And I'm sure that we've probably all come across challenges where we've done a piece of work and then tried to evaluate it at the end and struggled to do so. So we're also encouraging people who are thinking about a learning system to think, well, how might you think about how you evaluate the impact of that learning system right from the outset? And as I say, Angela's posted the link to those web pages. And we'd be delighted to hear from anyone if you get the chance to look at the work that we've done around QMS or our learning system work. We'd be delighted to hear your thoughts and what's working for you and to challenge us in our thinking, because as I say, we're constantly learning and constantly evolving. So what are we doing now to embed the approach? So apart from the framework and the web pages that we've shared with you here today, we've been working also to think about how we can help organisations to create the conditions for quality management. So we've developed a driver diagram for creating the conditions for quality management with 4 primary drivers and some clear secondary drivers that is also available to share. We've developed a quite robust self-assessment tool to enable organisations or teams or healthcare systems to think about where are their strengths, where are their gaps, how are they balancing all of these aspects of quality management, and helping them to identify through their gaps what they might want to prioritise in terms of an action plan. And we're just always looking for opportunities to learn with others about their experience of quality management. So one of the teams within the Improvement Hub in Healthcare Improvement Scotland is involved in a value management collaborative, which is supporting teams at a microsystem to apply a quality management system to the work that they're doing. And we're also looking for opportunities to work with a whole variety of parts of the healthcare system so that we can encourage that learning system approach to learn from each other. And just in our own team, just constantly thinking about how can we make quality management a habit within our team and how might we share that more widely. So that's a quick whirlwind tour of Healthcare Improvement Scotland, how we developed our quality management system framework, and just I wanted to highlight some of our evolving thinking. And as I say, I'm so looking forward to just interacting and learning with you all throughout this webinar series and just continue to develop our thinking over time. So thank you very much, Emma.
Thank you so much, Michael. That really started us off very, very well. Thank you. And one of the things I took away really was this thing around language. So how it lands with people and the responses you're getting. And I think that's really interesting theme for us to think about, as well as the technical bits. How is it landing? What is it you're talking about? So thank you so much, Michael, for that. Thank you again for sharing all your resources as well. So I'm sure people will be really interested in that. So to keep us to time, I'm going to hand over to Dr Amar Shah from East London Foundation Trust. Amar, if you'd like to introduce yourself, we've spotlighted you so everyone can see you. So thank you for joining us.
Thanks, Emma, for the invitation to join today and to share some of our learning around quality management systems. I'm Amar, forensic psychiatrist and chief quality officer at ELFT. And what I thought I would do, I mean, I have no slides today, but I thought I would share our journey around quality management over the last 10 years, because I think part of the learning really is in how it's evolved over time. Ultimately, I'm not sure that any organization would really be able to introduce this in one go. It's probably something that you would introduce gradually and build over time. So I thought I would share how we developed it over the last 10 years. And it begins really with looking back to 2012 and what was then a very traditional healthcare provider, mostly and entirely focused on quality assurance as its only approach to quality, really. So at that time, we were a mental health and community health provider with the approach to quality being that we would check and we would use audits and inspection to help us understand where things weren't quite up to the standard we expected. And then we paid attention to the places where there were gaps and helped them to address those gaps. Pretty traditional quality assurance. And that took us so far. And in about 10 years ago, we had a number of sentinel events, some really serious safety events, which forced the organization to really question whether its approach to quality was the right one or was inclusive enough. And that's when the organization first looked outside and started to think about how others across the world achieve the very best performance and quality in health. And for the first time came upon quality improvement, continuous improvement. And so I guess the journey into quality management begins from a position of already having a fairly evolved approach to quality assurance and then starting to introduce quality improvement to it. So in 2014, we began applying quality improvement as an approach to deeply involve people close to quality issues to discover new solutions, test them out and learn what works. And that became a really important mechanism for us to tackle some of our biggest quality issues across the organization. So I guess the quality management system first it begins with this balancing of quality assurance and quality improvement, trying to bring in QI alongside QA. And what we did in those early days was try to think about quality assurance first of all and say, what's in our quality assurance work did we no longer need to do? What could we reduce down? What could we do in a more meaningful way to allow space for quality improvement to flourish, people to allow them some space and time to be able to use it, to be able to make improvements to the system. And so the first act for us really was about balancing the quality assurance and quality improvement activity and finding a way for them to live alongside each other, led by different teams with a sort of a Chinese wall in between them, but also which allowed learning between the two to move. So the things that we learned from quality assurance fed into quality improvement, and then our improvements that we made from QI work also fed into what we then used our assurance work to check that we were meeting standards against. One of the first really big complex issues that we tackled system-wide was inpatient violence. It was our number one most common safety event. And over the course of a number of years, we managed to apply quality improvements and find ways to predict and prevent violence from occurring on our wards. So from starting with one ward, we then managed to scale up successfully across all of the 50-odd wards and have been able to sustain that over many years, so that we have 30% less violence now than we did back in 2013. But the learning from being able to test and implement new ideas into clinical practice to be able to tackle successfully a really complex quality issue, then moved us into the space of thinking, right, how do we really enable teams to hold on to this? Which obviously is the introduction into quality control. So from starting out with a focus on QA, introducing quality improvement into that in 2013, 2014, a couple of years later, we were starting to explore what quality control meant for us. How do we enable teams to manage quality day to day, hold on to the gains that they've made from QI, and what would a really good quality control system look like? So that as you complete quality improvement work, you move it into quality control. And so we started experimenting with teams and learned really what the key components were of quality control. Thinking about how do people come together in spaces where they can discuss and meet together. What sort of data informs that conversation? How do they take action on what they discuss and identify as things that need management? And how do they escalate? All of those components to really good quality control we started to experiment with and build across our systems, but it really came from successful QI work, and that being the spur to thinking, right, how do we hold on to this, and starting to develop QC systems. And then I suppose our approach to quality had matured to an extent that we then were able to start thinking, how do we use improvement more strategically? How do we think about ensuring that every part of our organization plans and prioritizes their improvement for the year ahead? And so that's naturally the introduction to quality planning. I don't know what your organizations are like, but I was, used to really see planning mainly as being something that was done for the purpose of others rather than for ourselves. There was often a requirement to produce a plan from the center of the NHS, which we used to create, but really very little involvement from people. It was always for someone else's reason. In 2012, if I look back, we had no organizational mission, no clear strategy. And so, really the approach to quality over these many years has started to help us become a little bit clearer about direction and strategy. We created our first 5-year strategy in 2013, our first ever mission as an organization. We refreshed that in 2017 and again in 2021. So developing 5-year strategies, which really deeply involve people in co-creating those. We have about 1,000 people involved every time, staff, patients, partners in our local communities, all helping us really think about what our purpose is and what we need to focus on for the next 5 years. So that is part of planning, and starting to get a bit more systematic and involved in the way that we plan and prioritize. And we've evolved from there to now using the annual planning cycle as the delivery mechanism for our 5-year strategy. And so we've reached a place now where we have a single integrated planning process. So all parts of the organization are supported to distill down what their key priorities are going to be for the year ahead in helping them move towards our mission and delivering our strategy. Now, that obviously being integrated, it means that it's not just focused on quality. It's helping each part of the organization think, what do we need to be delivering across all of the breadth of our functions, thinking about quality, performance, finance, people, all aspects, and thinking what are our priorities for the year ahead and how are we going to deliver them. So we now have a system that obviously began with QA. We introduced quality improvement and have learned how to really apply that problem-solving approach to complex issues. Then started to think, how do we hold on to the gains from that using quality control, and started to develop and experiment with structures and data and processes that enable teams to manage operations day to day. And that's an area that we're continuing to learn more about. Currently got a 90-day cycle to help really continue to strengthen our QC processes, and then build on top of that some more systematic approaches to planning, and not just thinking about quality planning, but planning in its broadest sense. And I suppose the final thing I wanted to add to that is our quality assurance, which is where it all began, hasn't sat still. And actually what we've been doing is really innovating the way that we assure. Give a few examples of that. We're trying to make it as meaningful and as patient-centered as possible, patient-led as possible. So we reviewed all of our audit, trying to make it much more meaningful, much more locally determined, and much more frequent, so that teams audit and act on it, and then are able to measure again within 3 months, rather than having to wait 6 months or a year for another audit. We also wanted to make sure that all of our CQC work was firmly held within our assurance work. And so finding ways for teams to really make sure they were always ready for regulatory inspection. It wasn't something we did just when we heard that CQC might be coming, but actually teams are always ready. And we have a continual internal readiness program that makes sure that teams check that they can meet CQC standards and do peer-to-peer visits and learning to enable each other to make sure that they're meeting regulatory standards. And going even further now, we've designed a patient-led or service user-led accreditation program. So service users tell us what they would expect to see, what standards would really represent excellence for services, and then they actually go in and assess those services against those standards, and they actually give feedback to the services. And then when they do that, the services are accredited. They get a gold, silver, bronze rating and a badge that they can then be proud of, and the service users also work with the service to help them make improvements to get to the next level of accreditation. So our assurance is also innovating at the same time. And the key to all of this really, I suppose, is to support teams to make sense of what they do day to day in terms of these 4 domains of quality management, so that they understand that what they're doing day to day, how does that, which parts of that are assurance, so that they can be really clear about the purpose of the activities they're undertaking. What are they improving? What do they use to manage things day to day in quality control? And how often and how do they plan for the future and delivering our strategy? So I guess out of all of that journey that's taken 10 years and is still work in progress, I guess my key messages from all of this would be, it's something that probably needs gradual development. So I'm not sure I would start with trying to design the perfect quality management system and implementing it. I think I would apply an improvement approach to this and gradually build it over time. And I think that's important because the understanding and maturity about quality does change in the organization over time, and people's recognition of how this needs to filter into other areas beyond just quality. It probably opens up over a period of years. My second key point is, I think a quality management system isn't really a quality management system. It's a management system. In fact, it's the management system. So calling it a quality management system, in fact, I never call it a quality management system at ELFT. It is our management system. And often I don't even use the word quality. It's about, how do we assure ourselves that we are safe and meeting standards? How are we improving? How are we holding on and managing quality day to day, managing things day to day? And how do we plan? And it's got to be viewed as being much broader than just about quality. And to be able to really do that, you've got to be able to influence way beyond quality. You need to be able to influence the way that you create strategy and plan. You've got to be able to influence the way that you access and use data. You've got to be able to influence the way that you assure. You've got to be able to influence operations. And so if you really are intent on integrating a single approach to management, you've got to find ways to influence colleagues and functions that go beyond quality. And I guess I would say that the CQO role, the Chief Quality Officer role, has really helped with that, because it gives me board level oversight of this. There are only 2 or 3 CQOs in the whole of the UK. So I think this is an opportunity for us to really advocate for a role which can oversee the organizational approach in this way and influence across a number of different functions. I think the final thing, final message from me is about trying to keep this real and relevant. There's no use having a theoretical framework if it doesn't land and make sense to people at the point of care. So language really matters. You've got to keep it simple. You've got to really connect people to it in a way that makes sense to their day-to-day work and help people make sense of their day-to-day work in this way. It's got to be helpful for people to know, okay, now this is the challenge I'm facing. And so the best approach really is assurance, because I really want to know is, are we meeting this standard or not? Or I've got this complex issue and the way I want to solve it is going to be through improvement. So that's where I go to in my management system. And here's what I use day to day to manage things in operations. And these are the control systems that I have in place. So I think keeping it real and relevant and avoiding the temptation to just produce the perfect theoretical framework, keeping it simple with language, and really allowing people to make sense of their work using this sort of management system, I think is pretty important too. So Emma, that's what I wanted to share today, as a bit about our journey and some of the key messages and learnings along the way. I hope it's been helpful.
Extremely helpful. Thank you so much, Amar. I'm really glad that this is recorded, because I feel like I'm going to rerun this again and again, so I can pick out all the bits and little nuggets of advice that you've sort of given us. I love the things you've been talking around starting in different places, having an organic sort of evolving approach to things, and really focusing on what's important to teams and what's the purpose for them. And then I particularly love the service user involvement and accreditation that you're building into the whole thing. Personally, I feel like I want to rerun it and listen again and again and sort of take it all in. So thank you so much. That's brilliant. So what we're going to do now is if you're feeling like me, you probably want to blurt it out and talk to someone else right now. So what we're going to do is just give you 15 minutes in a breakout room with some other people. We'd love you to just say hello, who you are, and just share some of the thoughts that you've had from listening to Michael and to listening to Amar, and what you're starting to think about. What are some of the things? And if you're able to whack that in the chat as well, then we can record some of those thoughts and feed them into later webinars and also into the panel discussion in a bit. So I'm going to hand this over to Shah, who I should have introduced as being our wonderful tech support today. So Shah's going to send us all into breakout rooms, and we'll see you back in 15 minutes. Okay. Shah's going to give me the thumbs up when everyone's back.
Recorded. I'm just doing a bit of getting everybody on mute. Where is my pod? I think that's everybody.
Okay, thank you very much. Well, thank you for joining us again. Thanks for doing your breakout. If you've got any comments you want to stick in the chat, we'd really welcome them. I hope you had a really good discussion. I bet there's loads to think about, but the good news is there's another 3 webinars coming, so you can think about it and in those as well. And in a few minutes, we'll also have a panel discussion. So if you've got some burning questions, please save them for then. So now what I'm going to do is I'm going to hand us over to Nicola Burgess. Nicola, you've got control of the slides. Would you like to introduce yourself and tell people about some of the research and evaluation that you've been doing?
Yes, indeed. Thank you, Emma. Excuse me, I have got a bit of a cough this morning, so hopefully it won't interrupt things. So my name is Dr Nicola Burgess. I'm a reader in operations management, and as Emma said at the start, I've had a long-standing interest in service improvement, particularly within a healthcare context. And I've been leading the evaluation of the NHS-VMI partnership since 2018. So it's a real pleasure to be able to share some of our findings. So thank you for inviting me here. So for those of you who are unfamiliar with the NHS-VMI partnership, this was a tripartite partnership between 5 NHS trusts, the NHS Improvement and Virginia Mason Institute. So if you're not familiar with Virginia Mason, they are a US-based healthcare consultancy who specialise in the development of management systems with a focus upon sort of lean-based improvement methods. So I'm going to share with you some of our main findings today. I'm just going to start my timer actually so that I don't go over. So I might have skipped a slide. Yeah, so the first thing we ask ourselves is, as in leading the evaluations, we need to understand, from the perspective of the intervention, what does success look like? So what are we trying to achieve via this partnership? And we were quite surprised to learn that despite being a nationally sort of led intervention, there wasn't actually a suite of explicit targets associated with this. In fact, we were very careful not to be explicit about the targets and instead take a much longer term view about building a continuous improvement capability. So much like what you've heard from Michael this morning and from Amar, this is a long-term incremental thing. And it needs to be focused on developing learning so that we develop the capability to be able to continuously improve our systems. And so here are a couple of quotes from some of the interviews and observations that we did. So on the left-hand side, this was the response from NHS England and NHS Improvement. Very, very clear that this is about developing capacity within organisations and thinking about continuous improvement for the long term, that it needs to be sustainable, and that these 5 organisations that were working with Virginia Mason should be able to continue the journey for themselves at the end of the 5-year intervention. And then on the side of the 5 CEOs that were associated with this intervention, they did talk about, having a long debate about what do we hope to see at the end of this. And again, it's quite vague in terms of what we're expecting, but we would expect to see improvements in quality of care, improvements in staff morale, improvements in financial position. But they were very clear that we are not going to be explicit about saying we have to be at a certain point by the end of the partnership. So that in itself was very interesting. I really like this way of putting it from one of our respondents in one of the 5 trusts. I think she really captures the essence of the management system, if you like, that we're trying to develop here. So she said at the end of the partnership, they want to say, well, we're going to scrap it. We're not going to do this anymore. Actually, you can't, because it's like somebody's chopped up anchovies and stuck it right into the sauce. There's no getting away from it. It's truly embedded. So that really is the goal and the objective of this intervention. Naturally, we need to measure improvements. We need to understand if it works. And although this is very hard to do at an organisational level, okay, for various reasons, and most critically, it's really hard to be able to say that improvements we've done here have led to improvements at a much higher level at an organisational level. But at a process level, we had lots and lots of data. And so here is a bit of a snapshot of some of the analysis that we did. So between 2015, or rather 2016, and July 2019, we looked at 28 value streams and 113 rapid process improvement workshops. So this is across all 5 organisations. And bringing all that data together, we could say collectively that activity or service times that were targeted by these process improvement workshops reduced the lead times by 62%, which represents about 3,020 hours of time saved, or I think it was 126 days if you divide that by 24. So substantial improvements in terms of lead times. Similarly, quality defects fell from 57% to 21%. Oh, that shouldn't have happened. And all of our trusts reported around about 50% and over in all outcomes that were targeted through their process improvement workshops. So there was a lot of improvement happening at a process level on the ground within all 5 organisations. I don't think we can get away from the fact, if you're familiar with the organisations that were involved in the NHS-VMI partnership, that performance outcomes at an organisational level were very different across the 5 organisations. So one of the trusts was rated outstanding in 2019, which was a significant achievement, and the chief executive and the executive team would be absolutely crystal clear that this was because of the project. There were other things going on, but certainly the intervention with Virginia Mason Institute was really instrumental. One of our organisations significantly improved their financial context, so they reported a surplus for the first time in over 20 years. Another won an award for safety for their work there, but 2 went into special measures. So it's a really interesting intervention to be evaluated, because we've got 5 organisations implementing continuous improvement intervention in the same way, with the same level of resource, but completely different outcomes. And so what this has enabled us to do is to really try and understand and explain the differences, and that explaining these differences can help with broader learning about how to foster a quality improvement culture across a healthcare context. So one of the most impactful things that we did was we looked at how knowledge about quality improvement was being spread through these organisations, because healthcare organisations are very complex, thousands of staff. How do we, because we can't train everybody at the same time, it doesn't happen overnight, how do we track how that knowledge is being mobilised across an organisation? So we did something called social network data analysis. And we use a very simple tool, which you can see in front of you now. And it's purely about asking participants. And in this case, we asked people who had completed the Lean for Leaders training program. And we wanted to know what they did with that knowledge, having completed that program. Do they mobilise their knowledge with others? Do they connect with others to talk about improvement? And so we asked them, who do you speak to about improvement? Who do you go to for advice? And then who comes to you? And then we were able to put this data into a software program called Usenet. And I'll show you the results of that in a moment. But just before I show you the network graphs, these are the sorts of things that we're looking for. So on the left, what you can see is a centralized hub and spoke network. So you can see there's an individual at the center who may have many connections, but it's a low degree of interaction because you have one key source of information. So in a network that has centralized structures, there's a low capacity to facilitate learning and knowledge transfer. Over on the right-hand side, what you can see is a very distributed network, so a high degree of connectivity. You can see, you know, the dots that you can see are nodes and who they are connected to. You can see that in this example, everybody is connected to one another, which means they have a high capacity to facilitate learning and knowledge transfer. And so I'm going to show you two of these results, because these two organisations that I'm going to show you are of a similar size. So as organisations, I think they each had about 6,000 employees, so sort of medium-sized trust. They had trained a similar number of employees in Lean for Leaders. So our sample size was very similar. And they had also made similar progress with the technical elements of implementation. So they had run lots of rapid process improvement workshops associated with value streams and so on. So it's really great comparison. This Trust A was an outstanding trust, and hopefully you will recognise that this is a very distributed network. So everybody appears to be talking to one another. We can see a high degree of connectivity and a high degree of interaction. So compared to the other trust here, which had gone into special measures, unfortunately, what you can see here is you can see lots of isolated components, so lots of decentralized networks, people, hub and spoke models not talking to one another. There's a small dense cluster sort of towards the bottom left, and that was among our improvement facilitators. But aside from that, what you're seeing here is sort of messenger-based interaction, okay? So just a hub and spoke model, very decentralized. So it's really a visual reminder about the importance of relationships that I think both Michael commented on and Amar, and the difference that that makes in terms of collaboration and knowledge mobilization. So if you get into the math behind the graphs, so the graphs are very visual, and you can see straight away the level of connectivity within these organizations. But if you look at the maths, what we're looking for is a degree that these relationships are reciprocal. So I go to this person for information and advice, and that person comes back to me. And in Trust D, we noticed that almost all of the interaction that was happening is what we call simple brokering. So we're purely passing on a message. Whereas in Trust A, it was very much about reciprocity. So everyone's talking to one another, which was a really fantastic context for improvement and collaboration. We did a whole raft of interviews as well. I think we completed about 300 interviews across the duration of the evaluation. And it was really evident in those interviews the different character of those relationships and how they enable or suppress collective reflective talk for improvement. So if we just contrast these two statements, they were talking about Lean for Leaders training at Trust Day. You know, we've not been on the Lean for Leaders training, but we're interested to do it, and we heard about it, and that makes us want to go out and find out more. At Trust D, it had the opposite effect. They felt that people who had been on the Lean for Leaders training, and perhaps just come a bit back to the language issue that we brought up earlier, you know, the people that have been on the training, they love it, but those that haven't feel excluded, and that sort of leads to knowledge being locked in and not shared, almost to the extent that those with improvement knowledge become ostracized within the organisation. So we were interested to understand, you know, about receptive context, and a receptive context, really a great way of thinking about it is to consider it like firewood. So firewood can be seasoned or unseasoned, both can be lit, but the performance will be significantly different. So when firewood is damp, it will smoulder, release toxic fumes and extinguish itself over time, much like improvement. If we haven't got that receptive context, we might do some great improvement projects, but over time they tend to wither and wane and you know, disappear. When it's seasoned firewood, i.e. you've got a receptive context, then we can burn bright, we can, you know, it becomes contagious over time, and you get enough resource that it becomes self-sustaining within the organisation, like the anchovies that we mentioned earlier. And so what was really clear through the evaluation was that context and culture shape improvement. And in the interest of time, I think I've got about 2 minutes left, it's worth saying that in all of our organisations, it was really noticeable that the organisations that had the most receptive context had engaged in what we call cultural work prior to the VMI intervention. So they had created antecedent conditions that shaped the receptive context, which meant that as the intervention with VMI progressed, they were able to gain traction far quicker than those organisations that didn't have a receptive context, because that work still needed to be done. Okay, and a receptive context can be facilitated by having clear, concise and consistent shared organisational values, being really clear about what they are from the top of the organisation every day. Having distributed clinical leadership to foster interprofessional collaboration was really important, and also creating formal spaces, if you like, for formal interaction to occur. So how did we foster those relationships that we saw in Trust A that was so successful? Okay, so I think I'm going to have to finish in a moment, so I'm just going to quickly skip through these slides. And I just wanted to show you this one. So again, it's a case of looking at our interview data to support some of the themes that we were seeing. And this is a really interesting contrast between what we need to achieve within our organisations to be able to lead quality improvement across the whole organisation. So on the left, we've got the consultants here, they rule the place. And on the right, we've got a chief executive saying, well, I'm not in charge anymore. You know, the clinicians are. And that's all about culture and leadership. So on the left hand, similar statement, but driven by fear. And on the right hand, it's driven by pride. So what we have is an organisation that is clinically led, managerially enabled. Okay, so we had in this particular organisation, the clinicians had undergone extensive leadership training, so 2 years worth of leadership training prior to the intervention, and that meant that they were able to lead in ways that foster interprofessional collaboration. So I'll just take you to my last slide, which is this one, just to let you know that we have some videos with our chief executives that were part of the NHS-VMI partnership on a website here. And you'll also find some blogs where I'm talking in a bit more detail about the importance of creating formal spaces for informal interaction and so on. So I'll leave it there. Thank you.
Thank you very much, Nicola. Really, really appreciate that. I love listening to Nicola talk. Worked together with Nicola for a long time now, and I could have let that go easily for another half an hour. So I hope you all enjoyed that too. Thank you very much, Nicola, and thank you for sharing those resources, because I'm sure everybody on the call will be pleased to be able to go and find out more there. So we have a little bit of time now, everyone, for some questions from the panel. We have Michael, Amar and Nicola still on the call. So if people want to put their hands up or want to put a question into the chat, now is your time. We've got about 10 minutes left before the end of the session, and this is the opportunity now for questions. And whilst we're just waiting for you to think of your questions or think about what you want to put into the chat, we will also be putting a poll into the chat just to get your feedback on the session and what you found helpful for today, and I suppose what your takeaways from the session are. So as you see that go up into the chat, do please contribute there. It helps us get feedback from these sessions and also think about how we can improve these going forward and apply our own approach to ourselves in terms of doing these webinars going forward through the year. So please do use that as it comes up. So I'm curious, does anyone on the call have any questions here for any of our panel? How have you found today? What has sparked an interest for you? Oh, none yet. None yet. Come on. So I've got a question then. So what I was really curious about, Nicola, particularly in yours, and I've thought about this before when I've seen some of the earlier work research there, in terms of fostering those relationships, what do you think improvers might be able to do from where they are in an organisation to help foster those relationships? Maybe they haven't got a big programme, maybe they haven't got a board all saying let's do improvement. What is it they could do to start to build those networks to help make quality management, quality improvement and so on a reality?
Yeah, that's a great question, Joy. Thank you. I think sharing some of the work that you've done, I think is really, really important, and finding ways to be able to share that. And I know it can be difficult, but things like newsletters, sometimes posters, those sorts of things that can help get the word out. Talk about it as much as you can and as often as you can. And the other thing really is to ensure that you've got executive engagement. And I think somebody else mentioned that as well. I think Amar mentioned Chief Quality Officer. So at one of our trusts, we had a director of Kaizen, but having that connection with executive teams and executive management was also really, really important.
Lovely, thank you. So we have a question come up on the chat now, which is how might QI leads ensure QI is as important as KPIs? And that's from Jane on there. So I'm just wondering if Amar might want to take that one first, and then I'll look for the next one for Michael. Go on, Amar.
Thanks, Jane. Well, so this is really about leadership, isn't it? Because this is about what we pay attention to. What we know and what leaders pay attention to is what others see as being important. So this is not one that QI leaders by themselves can influence. This is, I think, part of my message was that we have to go out and influence way beyond quality. So this is one that we have to be able to influence operations and performance. To think how do we turn KPI contract assurance into something that's really meaningful, so that there isn't this disparity between the stuff we work on in improvement and the stuff that we're measured and performance managed against through another assurance mechanism. They need to be starting to converge, and there are ways to do it, and there are good examples of places that have started to bridge that gap. And we need to take commissioners and partners along with us, and a good opportunity now with in England, certainly with the integrated care system, to be thinking very differently about performance. And we can be offering our skills as improvers to help the system think about how we introduce those into performance, and not just see them as something that just sits within the quality domain.
Lovely, thank you, Amar. Okay, right, I'm going to get to another question to try and get as many through as we can. So Wendy, hello Wendy, says the group in the breakout were interested in where ownership of the quality management system sits and how this enables and how it's introduced. I'm wondering, Michael, with the work you've done in Scotland, how did you start, I guess is the question there. Yeah. Oh, we can't quite hear you still.
Sorry, Joy. Sorry, I beg your pardon. Right. I was muted. So how we started and how we're going currently is probably quite different. But in terms of ownership, I think I would probably go back to something that Amar said, and it's something that we've reflected on as well. I guess it depends on where you want to start and how you want to start. So we've talked about a quality management system applying at a national level, at a system level, an organisational level, or a team level. But I guess the ownership is about everyone buying into that vision and being connected to that vision and feeling a visceral connection to that vision, so that everyone feels a part of it. I'm kind of repeating something that's been said before, but the importance of ensuring that our senior leaders are engaged and committed and trying to work hard to embed that culture is crucial. But I think it needs to be owned by everyone, and we need to be ensuring that we're creating the conditions to help people feel, you know, if I'm working in a team and I can see something that's not working quite right and needs to be improved, that I have the power, that I feel empowered, that I have the skills and the knowledge to make those changes. So I think ownership is probably about everyone having a part.
Lovely, thank you. There's lots of similar questions there, Michael, in terms of executive support and so on. And I've noticed in lots of sessions I've been in over the years, that's a recurring question people have, isn't it? How can I get more exec engagement? How do I get more exec support? So I think Emma and I will take that away and think about how we also build some more of that into the future webinars, because there's perhaps more of a deep topic we could go into there. So thank you very much. I'm going to go for one final question before we go, and I'm going to open it to all three of you on the panel, really, which is I loved what Amar was talking about around the patient-led accreditation. So what I thought we could start with is Amar, just a little bit more about how did you start that? What's the initial reactions? And then also just perspectives from Michael and Nicola around, you know, where you've seen that in other places, whether that's across different providers in Scotland or through your research around the patient involvement in developing quality management systems and quality improvement and so on, if that's okay. So Amar, if we start with you, please.
Yeah, that's a big question. And again, it's probably a journey of at least 10 or 12 years for us, starting out by just inviting patient representation on certain committees and engaging and consulting with service users, to then starting to realize the benefits of doing work together in partnership, and then eventually starting to really understand what true co-production and in fact service user leadership looks like. So now, and really this is about all of us feeling it, trying it, experiencing the benefits of it for ourselves and for the service users we support. And actually there are so many benefits of this, from better ideas to actual improvements in patient recovery and confidence, to you know, being able to work together collaboratively as a system. So the benefits to this are really very wide, and actually, you know, now we involve patients in every aspect of what we do, from research through to every interview panel, through to teaching, through to all improvement work. But it's a gradual journey to get there, and it needs a whole infrastructure of support around it to really enable it and to make people feel supported and make sure that their efforts and their contribution is really valued and respected.
Lovely, thank you. So Michael and do you have anything to add to that from your learning?
So I don't know that I've got anything to add, Joy. I think Amar just gave a fantastic answer. I think sometimes it's about being brave enough to try and get some wisdom and expertise behind you to help you to do that. We're lucky in our organisation that we have a community engagement directorate with support and expertise throughout the whole country. So I am no expert in co-design and co-production, but again, I have seen the benefits where we have involved patients and service users to influence change and influence improvement. And the more we do it, I think I'm signed up to us doing more and more of that.
Lovely, thank you very much. Nicola, last words from you on really building in patient listening into developing cultures of improvement and quality. Last word.
Okay, so I was just going to comment on the patient voice, and I think, you know, Amar gave an answer that was really the gold standard there, but certainly from the evaluation and from other sites that I've looked at, involving the patient's voice is incredibly powerful as a mechanism for change and for influencing change. And yes, we need to get better at it, I think, across the NHS, but you know, it's really, really important, really powerful and essential, really.
Lovely, thank you very much. We might go into that more in future webinars. I think it could be fascinating for all of us. So we're at the end of our session, everybody. Thank you all for being here. Thank you especially to our panelists and speakers. We much appreciate your time and all your insight and knowledge and sharing today. And we're developing our own network for developing that culture of improvement. So thank you for your time, much appreciate it. Thank you to everybody for joining the call, for your participation, for putting your comments in the chat, for joining in the breakout rooms, for giving your feedback. We appreciate all of that. And the final place to end, everybody, is the next session is coming up on the 8th of April. We are going to be talking about putting the man on the moon and aligning everybody to the strategy, really going into quality planning. So we'd love to see you there. Bring a friend if they're interested. If you have something you really want us to go into in that session, please do let us know. And thank you very much for your time, and have a great day, everybody. Thank you.
Thank you.
Thank you so much.